Okay, can everybody see it? Awesome. All right, my name is Jenna. I'm a clinical therapist with Healthy Minds with WV Medicine, and I work with kids and adolescents and families. Kristen also does the same. We did this presentation together. However, she's having some family stuff, so she may or may not be here. So, all right, well, the topic today is I think going to be really familiar to you guys. So I really welcome your questions and your comments and insights. So please feel free to include those in the chat. And then at the end, I really would love to hear if you think of a case that resonates and want to share that, I would love that. So today we're going to talk about trauma. And this is a huge topic, so we're really going to focus briefly on definition and then two common presentations that we see often as therapists, and that's blocked trust and an overreactive stress response. We're going to look a little bit at those and then look at some interventions that help kids feel safe and regulated. And we'll do a case presentation. We do have a case presentation prepared, but if you guys have a lot of stuff that you want to talk about, that would be my preference. All right. Okay, second. Okay. I'm just going to put this all on here. What is trauma? You guys work with it every day. However, I think it's helpful to kind of understand a little bit of the nuance. Trauma gets thrown around a ton, that word, which is fine. We're not going to go into that discussion. But what we're talking about is trauma that is by definition overwhelming our nervous system. So it overwhelms our capacity to cope. And it is really by definition unbearable and intolerable. That's kind of your textbook trauma. And really, we don't have a diagnosis that captures anything but PTSD. But what you guys see every day and what we're dealing with therapists is really more this complex trauma and developmental trauma. And basically that means that it's an exposure to multiple traumatic events. It's often invasive and interpersonal, and that the effects are pretty profound. And developmental trauma builds on complex trauma, and it really highlights this fact that it impacts a kid's development in ways that now we're seeing as kind of patterned and predictable. This is not a one-time event typically. We're looking at chronic impact. Unfortunately, our diagnoses do not reflect this nuance, and we end up really just diagnosing the behavior, which says nothing about the reason, and it can really limit our interventions if we're not careful. So these kind of predictable pattern ways of how chronic or relational trauma, that's another word that gets, or a term that some therapists use that feel it's more reflective and accurate of what kids are experiencing. Researchers, and this is mostly Dr. Bruce Perry and a few other folks who have highlighted and done the research that show there's really 7 domains that we see that kids are impacted. And that's attachment, that's our kind of our understanding of who we are and how we see ourselves and how we see people who are supposed to take care of us. Biology, you know, a lot of these kiddos in the system have increased medical problems. They have sensory issues, affect regulation, have a really hard time identifying their emotions and controlling them, disassociating, and that includes memory problems. Often we have kiddos who just have a hard time remembering things. And we see that a lot in school, like spelling tests. They know it one day, they've forgotten all the spelling words the following day. And that's really connected to disassociation. Behavioral regulation, that's a no-brainer. That's why most kids come to us. And that looks like impulse control problems, and aggressiveness, oppositional behaviors, cognition, learning difficulties, and self-concept, which is really connected to attachment. And often the kiddos we work with and that you work with have a pretty narrow view of themselves, and it tends to be pretty negative. Okay, so again, there's a lot of presentations in terms of kids who've experienced early trauma, but two I feel like come up a lot, and that's blocked trust and an overreactive stress response. So I'm really just going to look at those two today. And we're going to start with the overreactive stress response, the tornado. So overreactive stress response is exactly the title. Kiddos have a really low window of tolerance. That's that green piece. And so if I'm in my window of tolerance, I am pretty calm. I have access to the front part of my brain. I can think, I can feel, I'm comfortable. Like right now, even though I'm a little bit stressed because I'm presenting, I'm still in my window of tolerance. I can function. Kiddos who have early neglect and abuse have a very small window of tolerance. And they really struggle once they're out of that to find it again. And they need grown-up help to do that. Often we see them in hyperarousal, and that's kind of that, they're bouncing around your room, they're talking really fast, they're not able to focus, they're emotionally distressed, they might be in a tantrum, unclear thought patterns. It can look like ADHD in that moment. They're just bounce, 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 bounce. And it's really hard to control them. The opposite of that is the hypoarousal, and that's the kind of numbed out, really poor eye contact. You might almost want to like snap your fingers because you're like, hey, I'm here, let's talk. And they're just shut out. And sometimes we hear parents just say like, they don't listen, they don't hear me. And often they're in that hypoarousal state. So what's happening in their brain, this is a pretty common graph that Dan Siegel came up with, and it's kind of that flipping of your brain. And really the big point here is that when their brain is flipped, this thinking part is not connecting to their feeling part, and they really cannot think rationally. And what they need first is to feel safe, and it really is a visceral feeling. Another way to look at it that I really like is this highway system. So if I feel safe and I feel good, I'm going to observe things around me, interpret it, process it. I might evaluate some options, plan, act, right? And that actually happens pretty quickly if you're a healthy human. And then you make a good choice. If you're feeling unsafe, you go straight to acting, and it's not well thought out. It's just a safety thing. So that's your fight, flight, freeze, or fawn. It is not thoughtful. It is just about being safe. And in kids, it looks incredibly disruptive, and often really mismatched with the environment. And what happens if your environment is constantly unsafe, that long road of thinking, planning, observing, and acting, it gets weeds, it gets rocks, because you're just not using it, and it becomes harder and harder to access. And then that shortened, I'm just going to act, becomes your default. And those are the kiddos that were like, oh my goodness, they go from 0 to 100. It's like a light switch went off and they're a different kid. And that kind of becomes what feels most comfortable to them and most accessible. So what does this look like? It looks like a kid who is hypervigilant. They are watching their environment, especially the grown-ups, to check for safety, and they may very well see unsafety where there is none. If they're out of that unsafe situation, they're still gonna be really sensitive to it. They overreact. You might notice fast heartbeats. You might notice dilated pupils. The flip side is really zoned out, inattentive. And then you can also see a really quick regression when kids feel unsafe, where they just go back to a much younger age. And that can look like bedwetting, thumb sucking. Also can look like really quick temper tantrums for very little things. And there's also this piece that they can do a repetitive playing out of the trauma events. And then if they grow older and we really are not treating this, they may become over-controlled or perfectionistic. There's a rigidity. They may constrict their emotional experiences and interactions. Rely, and this is a really big one, especially as we hit the teenage years. If they have not learned to widen their window of tolerance, then they will reach for really quick solutions to feel better. And that can look like substance use. It can look like a lot of sex. It can look like self-harm.
Jenna, can I add something really quickly?
Yes.
I wanted to just point out, I know you mentioned that more of like the substance use, sex, like all those things can be related to teens. All of these responses can be generalized to any age. I know I've got a lot of teenagers who will do the quick regression where they're sucking their thumbs or twirling their hair. So just to be aware that these behaviors can be seen at any age.
Yeah, great point. All right, blocked trust. This is another really common presentation. And it's basically kids don't trust other people, especially grown-ups. Sometimes peers too, but it's typically really directed at grown-ups. And this happens when the caregiving environment is not nurturing and the stress response is high. So that window of tolerance is tiny. They're living in either one a lot of the time, and there's no grown-up who's helping them feel safe. They learn to not trust that comfort and companionship will be safely given because it hasn't. They learn to suppress the social emotions. So those interactions that you have that are generally positive with other people, they just don't have them, or they're painful, so they suppress them. And this can lead to a chronic state of defensiveness, and you can experience blocked empathy. And I highlight this piece because we often hear, like, from foster parents or from parents in general, like, oh, my son just walks over to his sibling, smacks them across the face, and nothing. There's no sorry. It's like he doesn't care. He's like a little psychopath. But if you think about it, it actually makes a lot of sense. If we are social creatures, and if we're not learning about ourselves and others through positive experiences, what's the point? So we see a lot of blocked empathy. Really, the ability to empathize is just not there, or it's a very diminished capacity. This has a lot of text on it, so I'm not going to go over all of it, but what does blocked trust look like? I think this will feel really familiar. It looks like kiddos who resist authority. And even if they're now in a safe place, they're not buying it. I don't trust you, and I am not taking you seriously. These kids have a really hard time having playful, age-appropriate moments. They might be characterized as, man, they're just super independent and really serious. If you're feeling really optimistic, you might, oh, what a soulful child. They just, they feel things and they just are very put together. They don't trust in grown-ups' good intentions. It's really hard for them to accept the unconditional love once they're in a safe place. And these kids can be super controlling, and we might even call them manipulative, because it feels really good to be in control. That helps them feel safe. What this looks like is often a really narrow and negative self-concept. Again, we're social creatures, and it's really hard to figure out who we are if we don't have a lot of interactions. Stunted emotional responses, and all of this undermines safe, supportive relationships, which obviously has a ton of impact on their long-term development. So how do we treat? This can feel overwhelming. Thankfully, there's great research out there on kind of what do evidence-based trauma treatments for kids, what do they have in common? What do they look like? And pretty much all of them have these components. There's a safety piece. We're working hard for kids to feel safe, and that pretty much comes first. That's a lot of what you guys do. Regulating is a big piece of it. A relational part, really, you cannot do trauma work with kids outside of relationships. They have to have those. Some sort of trauma experience integration. So these memories aren't just like floating around full of triggers and big emotional responses, that we're integrating their traumatic story into a bigger narrative, and it makes sense. It's not the only defining thing about them. And then really working on increasing the positive affect, increasing those playful moments, increasing a bigger sense of who they are and who they can be. So we're not going to talk about all that today. We're just going to talk briefly about safety and regulation. Safety is really about, if you think about it, I like to think about it from kind of outside, like the environment. We want to diminish those stressors. Then you think about it in the kid's body, we want to diminish those stressors. And then in their brain, and that takes a little more skill because we're asking them to think through things. We want to give them more capacity to diminish their stressors. So from the outside in, that really starts with us. We might be the most lovely people in the world, but we are a new face to a kid, and we're almost always stressful to them. So our body language, our voice, our energy levels, we want to take that way down. I'm a pretty energetic person, but if I'm meeting a kid for the first time, I want to bring it way down, slow my voice down, have kind of an openness to my chest and neck that signals kind of I'm safe, I'm not defensive. You want to give really good eye contact if that kid is open to it, but also kind of back away if their body language is like, I need space, I don't trust you. You really want to be intentional about this. The research shows that kids are really good at picking up if we're unsafe. They're not so great at picking up body language and cues that speak to safety and kindness. So you really want to be intentional about that. The other piece is we want to diminish stressors in their environment. So that can look like good routines and rhythms at the bottom. If taking away, if they have a bunch of appointments, and I know a lot of these things are in our power, but noticing what is stressing out a kid in their environment. Is it too many appointments? Often supervised visits are really important for kids. As you guys know, they're also really stressful. So having a routine, a plan, forecasting what's going to happen is always helpful. And also including some like goodbye rituals. And this is what we do when we say goodbye. And this is what we do after we say goodbye. And really incorporating those. At school, is it the transition from one class to another that is stressful? Then let's try to problem solve ways we can diminish the chaos around them. That could be they get to leave early to go to their next class. This really is a time to be creative and to experiment and see what works and what doesn't. In terms of kind of safety, and this is kind of leading into regulation in their bodies, you want to practice attunement when you're interacting, and that's kind of what I already described. You want to meet their energy. So if I have a really hyperactive kid, you're meeting a kid for the first time and they're bouncing all over the office, I'm going to match their vitality. Like, oh my goodness, you are so excited right now. You have a ton of energy. And then I'm going to very intentionally slowly slow it down in hopes that that kid starts co-regulating with me. And slow it down. I might even go like, oh my goodness, you know what? It makes sense that you might be a little stressed right now. You've never met me. Whew, it's hard to meet new people. Okay, that makes sense. And I'm slowing down my breathing and I'm showing them how to calm down. That's attunement. And totally normalizing it. We're not correcting. They're just saying, I got you. I see you. You can have all these big emotions, but I'm a really sturdy, safe adult that's going to maintain like an emotional openness. I'm not going into robot mode, just sometimes where parents go, and staying emotionally open and available, but I'm really sturdy. Forecasting, routines and rhythms, we talked about that. Again, with the creativeness, a lot of these kids have sensory stuff going on, so noise canceling headphones are great. Calming music, and this goes into regulation. So I wanted to give a quick little example of a kiddo I'm working with right now. That's a good example of removing stressors and just trying to be creative and helping them regulate. So this kid has a really hard time sleeping at night. He goes into hyperarousal. He's super vigilant. He's had a lot of early traumatic experiences, including in utero exposure. So sleep, he has nightmares, night terrors, all the things. He has a really hard time calming his body down. So first, diminish stressors in his room. Where's his bed? Is it facing a window? That's actually scary for him. So we shift the bed around. What are his blankets like? Maybe he needs something a little more weighted. What is his ritual of going to bed? Can we not schedule nighttime appointments so we can have a good hour to calm things down? What's the noise like in his room? Maybe we can add some calming music. There's some anecdotal research that talks about kids who've had in utero exposure didn't get that calming, consistent heartbeat. So adding a stuffed animal with a heartbeat can be really regulating. So just trying new things to help this kid's sleep patterns and help them calm down. So we have those regulating the environment or trying to diminishing those stressors, and then diminishing stressors in the body from the bottom up. And that looks like music, calming music, those heartbeat stuffed animals can be helpful. Anything that's patterned, repetitive, and rhythmic has a really kind of stabilizing effect on humans, not just kids. So if we have the option between maybe swimming laps versus basketball, we'd want to go towards swimming laps because that's patterned, repetitive, rhythmic. Drumming is really helpful. Anything that has that repetitive piece is going to calm things down. Sometimes just bouncing a ball, catch, bouncing a ball, catch, and we start our sessions that way. And you can just see kids come back down. The goal for this work is to reset their baseline stress level. So if that is a thermostat, we want it to come down, and each time they practice, they're learning how to reset that. But again, they really, really need help. The top down, you would really only do after you've done these other things, because top down, you're asking them to use the front part of their brain. And that looks like mindfulness, taking deep breaths, calming strategies like progressive muscle relaxation, giving yourself a big hug. But again, these are things you'd really want to practice before they're activated so that it's already a habit. They've already practiced giving themselves a hug when they feel stressed, and now they can do it. This work, I like to think of it as a lot of it's preventative. Like you want to incorporate these calming little like safe havens throughout a kid's day as much as possible. And that's preventative. You're helping them reset in the morning. Often exercise is really great for that. Like, let's do jumping jacks in the morning because they wake up with this energy. That's a reset. And then maybe before they go to school, another little reset. During school, working with the schools to have resets. Then when they come home, that's often a stressful time. They're hungry, they're overstimulated. We have a reset time, and so forth. The goal is really to keep kids in this window of tolerance, in this kind of river of flow where they can tolerate things, not on the bank of chaos where they're out of control, and not on the bank of really rigid inflexibility. Both of those we don't want. And that's true of adults as well, especially when we're parenting. We want to be somewhere in the middle and help guide kids through this river, because that's really our responsibility as the grown-ups. All right, that's it. These are references, and then questions or thoughts?
Thanks, Jenna. Great job. Like I stated before the presentation, unmute, put your questions in the chat, whatever you feel most comfortable doing. And I'll be mindful to look at the chat.
Fantastic presentation. Thank you so much. And I love how you pointed out multiple times throughout this doesn't just apply to kids. This is really for all the humans that we're working with. So such a great reminder.
Could trauma manifest like multiple personality disorder?
Yeah. Kristen, do you want to take that? I feel like you have more experience, especially with that age group.
Yeah. So I would be curious as to what you're seeing to have that diagnosis of multiple personality. Because oftentimes we see just a varying in behaviors and reaction. So that would be my first question. What things are you seeing?
Well, I've seen this person, like, they'll completely switch lanes and they won't remember anything. And they've actually given these lane switchers like different names.
Yeah. So absolutely. So right, that often comes with that dissociative states. Trauma will cause that to happen. When we're not feeling safe within our current self, we need to take a break and tap out and respond differently. And so we will often see those different like personalities have different characteristics of safety. So we would work to do much of what Jenna was talking about. How do we bring that back down to safe? How do we give the authentic self a lot of power and control to manage those environments differently? Other questions?
I'm curious to hear from you guys what presentations feel really familiar to you and anything that you've found helpful.
Don't be shy now. We can unmute or put them in the chat. Don't worry. Safe space, right? So don't worry, feel free to share.
Jenna, I found your description of like attunement really helpful, because sometimes I know our parents get angry or get anxious, and that looks like anger, and then that actually escalates the child versus de-escalates the child. And because they've often had their own trauma, there's this dance that they get into where they both kind of escalate each other. And so teaching parents how to do this, including caregiver, any caregiver, right, whether it be kind of CPS staff or adoptive parents or whoever's interacting with the kid, I think is so important. And also know you have a caregivers group. I don't know if you talk with folks. I just thought it would be useful for people to know about the caregivers group and the kinds of things you do with adults who are in that caregiver role to help them work on that attunement with kids who have trauma.
Yeah, so I facilitate a support and education group for caregivers of foster and adopted children. It includes foster parents, adoptive parents, and kinship caregivers. And we practice this a lot. And we spend a lot of time identifying what stresses us out and how we can regulate ourselves. Because that's a great point. Like, we can't be a regulating grown-up force if we're dysregulated. So that work has to happen first and simultaneously. And it's super hard.
Oftentimes what we spend the first chunk of treatment on is working to regulate not only with kiddo, but with parent. So even when we are in biological families, we have to be able to say, okay, so if I'm teaching your kiddo how to go outside and shoot basketball, we need to be able to recognize, okay, that's their time to take a break. How do I take a break while they're doing that too? Right? How do I take that time out? And I don't like using time out. Usually I use like, how do we take breaks? How do we take those resets? Because we both need to have that time. And it's okay that if we're escalating, saying, you know what, I need a break right now. Let's take 5 minutes and we'll come back.
Any other kind of final questions or comments before we move to the case? Okay. So we can go ahead and move on. If you do have follow-up questions, something pops in your head, pop it in the chat. We'll be sure to get to it. Kristen, I can share my screen if you'd like, if that's the best way to do it for you. And you can just walk us through it, a couple minutes, and then we can have discussions. Does that work?
Yeah, that works great.
Awesome. All right, give me 1 second here. All right, can everybody see that? Okay. Go ahead and take it away, Kristen.
So this is a case of a 16-year-old female. A lot of the clients that I see are adolescents, but they were initially referred to CPS after experiencing truancy. So the school reported them to probation, probation got involved, and then CPS was involved at that point. Later finding out that she was the primary caretaker at home. Her mom had struggled with paralysis, so she was caretaking with mom. The living arrangements were also very unhealthy, multiple people in and out of the house, not very clean and kept. Later, it was reported that she had experienced rape earlier in that year and was avoiding school too. She also has had those experiences of, she reported seeing people die by being shot. She has talked a lot about being sold for drugs by both her parents. and her dad is currently in jail for drug trafficking. So at this point within treatment, she has been removed from mom's care. And that's partially from probation, and then CPS has been in agreement with that and is living with maternal aunt. They are, from what I understand, they are able to be reunified. However, at this point, she is not in agreement with that. She continues to decline that. I have not been told of MDT meetings that have been happening. I do know that they have, I think, court hearings every 3 months, more in regards to probation, making sure she's staying focused on schoolwork. So with the agencies that are in place, so CPS is involved, probation, they have Safe at Home. She's coming to outpatient services, and then she also for therapy as well as for psychiatry. Like I said, she knows that she could go home at any time. And that seems to be the motivation that is always reminded of them. She will maybe fall back a little bit with her studies, and they'll be like, well, we're going to get ready to send you home. And then that kind of kicks her back into gear and say, okay, no, I'm not going to do that, because I know if I go home, these things could happen again. She has had contact with mom, or through text messages and phone calls, and mom is not happy with some of the choices that she's made in regards to reporting the abuse that she's had from the different people who've been in the house, as well as the most recent abuse she suffered from one of her close family members. So she tries to avoid home as much as possible. She has had some contact with the CPS worker, but then they requested a new one. They felt the other one was mean. I couldn't recall who that was, and has actually had a really tough time giving me accurate information on like who do I need to contact, so we can coordinate care. And I've tried to reach out to probation as well, and it's been a bit of a barrier. So some of those barriers to this case is that, right, not being able to coordinate care effectively with the CPS worker. It sounds like it's been changing at their request, as well as the probation. I haven't been able to work through traumatic events very well because we're still working on that safety piece, right? Environments are not safe. They've never been safe for her. And although she's in a safer environment, she's still struggling with those trauma reminders, fearful of running into the most recent abuser. She's actually had some contact with, fearful of men in general. So we're working on how do we maintain our safe environment? How do we get maternal aunt involved to keep to help reassure safety? So those are like the biggest pieces about this case. A lot of what I've seen behaviorally is she will isolate. She also gets she'll isolate whenever thoughts get really big. She is quick to react. So she would probably be one who would get like an oppositional defiant diagnosis, because asks her to do something and she responds quickly. She's the one that has the power or the limitations against authority. So that goes in all directions, whether it's at school or at home. Even coming into the office sometimes can be overwhelming and stressful for her. So she's had all of this history that then we can see, and working really hard to get her to recognize, like, it makes sense why you would have these reactions, right? You're trying to maintain safety when the environment itself is not safe. And then the folks around her to acknowledge and respond differently to help her feel safety differently. Any questions? I think my biggest question is, how do we help coordinate some of these cases differently, just so that we can all be on the same page and be up to date on where treatment's at? Questions?
So one of the reasons we started this particular Echo series was to improve communication. And so I think questions for anyone who's affiliated with Child Protective Services, like what are other ways of communication? What are the best ways to reach people? I actually had a case this past week. It was interesting because the patient was doing really well. And so I submitted a letter to the CPS worker that the patient was doing really well. And then very suddenly, the patient started not doing really well. And I was like, oh my God, I just sent her that letter saying this patient was doing really well. And so I needed to contact her saying, at the time that I wrote that letter, it was true, but I need to update you that the person has had a relapse and we're recommending a higher level of care. That communication occurred over email and was the most effective communication I've had, except for we are not really supposed to share protected health information over email. So I didn't use, full names and such. So that's our barrier to that communication, although it was fantastic. Like it was great. So I don't know if you guys have any thoughts or suggestions around like what's the best way for treatment providers to communicate with workers and have like an ongoing back and forth. So updates can be given in real time.
I deal with a lot of out-of-state providers, and a lot of their stuff is encrypted. A lot of the hospitals that send me stuff, it's pretty encrypted. I think DHHR, we had the ability to, but it's a little bit more difficult.
I think most staff have cell phones too, that they like both look through, they check their email there, but also text messaging. But I think that's a good point because a lot of the time our partners, whether it's at hospitals or other providers, are hesitant to communicate that way as well. Like as far as text messages go, because, they're always there and certainly less, in my mind, less secure even than our email is on our government email addresses.
And then Emily just put in the chat about the Virtue protection to encrypt emails. And we have a way to encrypt emails too, but I don't think you guys can read it. So that's not really helpful.
Yeah, I was going to agree with Matt and say that we do have I've had things sent to me that were encrypted also. So, I mean, we do have the ability to do that. I didn't know, Emily or whoever posted that. I didn't actually know what actually program it was, but we do have that ability. Or even if you just picked up the phone and called and said, Laura, like you had sent the report, and then even if you just picked up the phone and called and said, hey, I sent you that report, but I've got another one coming because it's completely different, and just let us know that, that I've got a totally different, it's gone the other way. And so that we know something different is coming, just even a voice, just a call to let us know something's different. And then we have that information.
And Colleen, I don't know if you want to unmute yourself, but Colleen knows more about encrypted things than me, probably.
Hi, everyone. Not driving. Sorry. I'm on mom duty at the moment. I just wanted to clarify. I use both a WVU email address and the state email address, and we can send encrypted to DHHR and DHHR can send encrypted to us. It's just an extra step of having to like log in or sending yourself a one-time code. It's kind of like dual factor with the email. So it's a little cumbersome, but you can definitely do it. From WVU, you just put brackets, secure bracket, and it will send. Now on the state side, you have to, like they noted, you have to have the Virtue protection on.
Okay. And so when like CPS worker or supervisor gets that secure email, they just have to sort of log in to.
I think there's some instructions we can find that I could send out about doing the secure emails that Colleen's talking about, that I can send to the group so they can see. I agree with Colleen. I thought there was a way to do that because we have the same kind of issues around certain data stuff that we do in our work. But yeah, so I'll see if I can find those and share those with the group. Hopefully they're not too confusing, but we'll send them out.
The only thing, Jay, when you look for those, can you look for how to open it on a mobile device? Because sometimes I have better chance opening it on my desktop, encrypted emails, than on mobile. But yes, I absolutely think that we can do that. And I know in working forensic with DHHR and CPS, we do a lot of, hey, I'm going to send you an email about, and I put maybe initials if I have to, or hey, that case that we've been talking about, I'm going to send you an email with some more information just to kind of give people a heads up with it while also trying to maintain confidentiality.
Yeah, we had the same comment, just send a heads up email, right? Say, hey, this is coming, or can you give me a call? So that was great. I know for the reasons why it doesn't really work that well with mobile is a security thing. Now it's getting better, but the desktop is like the preferred method because they're thinking you're on your WVU desktop, not your personal phone. But I think there's instructions for both. We'll clarify all that, but that's a great point that there is some issues with wherever you get access to those emails because we run into the same things.
Okay. And then Kristen, you sort of had a question about if you're struggling to identify who is the person, right, for this, like the case you presented, who's actually the contact. I don't know if people have thoughts about that. So if the worker changes and the treatment provider is like, I have no idea who the new worker is because the client doesn't seem to have an understanding of who.
So it looks like Brianna mentioned calling the local county office by phone and asking for a CPS supervisor. Then they can direct us to the most appropriate person.
Any other thoughts about communication or experiences with kind of reaching out and it not going well? Leanne just put the district managers list in there also. Thank you, Leanne.
Thank you.
Sorry, I'm not suggesting that you always call a manager, but that has all the information on it. That's a quick reference for you all too. I mean, but you can.
Do people have trouble getting in touch with us? Curious if it goes kind of both directions.
I would imagine initially it would be hard to get in contact with us because I know I've had folks have to call the call center and then a message comes to me and then that chain often is long. In my experience, what I have done, I give my office line to folks, especially after I've just confirmed that they are working on a case that I have, and it's usually my direct line. And if there's a message, the little red light drives me nuts, so I respond to it much quicker.
That little red light drives me nuts too. So if you call me
Thank you.
and there's a message, because my phone was just ringing and it was driving me crazy to let the voicemail come on. I wanted to answer, but I let the voicemail come on, but I will be calling that back as soon as this is over because it drives me nuts.
Yes.
But I have a list here with Ruby and everybody at Ruby in the Children's Hospital, but I don't have Chestnut Ridge. And I would love to have like a list of who I could contact or how to get a hold of people at Chestnut Ridge, if you all have a list like that for me. Because there was a few times, just for communication, I would have liked to have called Laura or called one of you all to talk about a specific case or something, just so we could have a conversation. But I'm not quite sure how to get a hold of you all. And it would have been nice just to have had a professional conversation between me and somebody, or somebody and I. My dad would have said, your grammar, Michelle. So, but just so somebody and I could have had a conversation about a specific case or something. So if you all could like get me that, or get all of us that, I'm sure all managers would like to have that.
Does that exist? Do we know if that exists other than in the directory, I'm thinking?
We can work on that. I don't have a list, but it would be good to have a list. We'll do it for ourselves as well as you guys. So
yeah, and Nikki, feel free to reach out to me if you need to, and I can connect you with, you know, pretty much anyone you need connected with. And that goes for any of the managers. Like, feel free to email me, and I have no problem making connections.
Okay, because I just feel like sometimes, but we've been on totally separate pages, and I don't want that. And I think we need to get back to understanding each other a little bit. So I really would like us to be able to have those conversations.
yeah, so Anna Butcher, we created a position, and I'm happy to say she'll be going full time. So she'll be even more accessible. This position, so there was almost like a single point of contact for liaising with Child Protective Services. So that's a good idea also, rather than figuring out, oh, who am I going to contact? Because Anna can look up who any given person's therapist is and connect you with the therapist. And obviously, as long as there's a release, we can share information that way. So thank you, Anna, is a great kind of initial point of contact if you don't know.
Okay, thank you.
Any final comments or questions? It's been great. Wow, I dropped the evaluation survey link in the chat. Again, if you don't click on it right now, do not worry, you will get it in the recap email. You do have a week to complete it, so no rush. Colleen, thanks for dropping your information into the chat. I'll be sure to kind of compile some of this stuff and put them in the recap email so nothing gets lost. If there's something you want added to it, you can just send me anything at any time and we'll get it out to the group. So just remember that. But we really appreciate Jenna, Kristen for both presenting today. Great comments from the group. And it was great to have some new people on the call as well. So welcome. We hope you found it beneficial and hope you'll keep coming. Our next session is going to be on April 19th, same time, 10 a.m. for an hour. We're going to be talking about the reunification process. And so that'll be Mickey and Terry and Rick, I believe, doing that one. So, oh, you're on mute. Go ahead, Mickey.
And Candy.
And Candy. There we go. The fearsome foursome. So they'll be ready to go. And so just be on the lookout for more. We'll send some reminders out with the links and everything like that. So just be on the lookout. But if there isn't anything else, we'll give you guys a couple minutes back.
Thanks so much, everyone. Good to see you.
All right. Take care, everybody.